Hi everyone, welcome back to the Hello Fam podcast. I'm your host Shalini and I'm excited to have you all here with us today. Some exciting new updates. We have just launched the Facebook community page to make our community content within the app more accessible to you and your loved ones. And we'll be releasing our next update soon on the App Store, so keep a lookout for it. To stay up to date on our latest updates, please make sure to follow us on LinkedIn and Facebook. And we also post on social media under the user HelloFam.app on TikTok, Instagram, and YouTube. Now, back to the podcast where we talk to longevity doctors, key opinion leaders, and others on their views into longevity. Our goal is to provide you with greater insight into the world of living long and well, as well as learn some practical tips to incorporate into your daily lives. Today's guest is a key opinion leader, so join me in welcoming Dr. Jeff Sternlicht. Thank you for taking the time out of your busy schedule to meet with us today. Can you give us a little background about yourself and how you got involved in Hello Fam, as well as any other hobbies and interests you have outside of a doctor setting?
Sure. Well, thank you so much for having me. I'm honored to be here. So I'm an emergency physician. I've been finishing up my third decade. So in July, I'll be beginning my fourth decade of emergency medicine. I started out in the early 1990s in New York City at a place called Kings County Hospital, which in the early 90s was one of the busiest trauma centers in New York City. Um, that's when I fell in love with emergency medicine. And I just loved the action. I loved the excitement. I loved helping people. I loved the fast pace, the diagnosis, etc. So that's where I started. I went on to do my training in Virginia, in Norfolk, Virginia. I did 1 year of internal medicine and then a 3 year emergency medicine residency. And then from there, I moved to Baltimore in 1998, where I've been ever since. I work at a hospital, um, busy emergency department, suburban, just outside of Baltimore. And I've been doing that since 1998. As I said, I've been department chairman since 2007. I also did some advanced training in point of care ultrasound in 2017, just so I really was able to stay up to date with the technology and optimize patient care. So the way I sort of got involved with Hello Fam is I've been doing this for a long time and I see people often at the worst day of their lives. The day they have their heart attack, the day they have their stroke, the day they get diagnosed with cancer or kidney failure. And it's frustrating because there are risk factors that could have been addressed potentially decades earlier that patients were not aware of. And, putting all that together, I have the opportunity now to tell people upstream before their events, perhaps how we can avoid that heart attack, that stroke, that fall when you're 80 years old and you can't get up and have a hip fracture and you're in a nursing home. So that's what sort of intrigues me about the preventative aspect and the educational aspect and the social media aspect and how we can scale healthcare so I can prevent people from coming. I don't want to have any business. I want the ER to be empty. And it could be much more empty if we took care of diseases more upstream than we see them now. So, as far as my hobbies go, I really like to be active. I was a runner in high school, middle distance runner, did triathlons in college, played basketball in med school, and then most of my adult life, I did martial arts, something called Krav Maga, which is an Israeli form of martial arts, which I practiced up until 2020. And the only reason I'm not doing that anymore is the school moved during COVID to some other location about an hour away. So now I kind of focus on like hiking, walking. I do a lot of strength training. I've been really pushing that for the last 5 or 10 years, just because as you get older, that's incredibly important. And I just love going to the gym and lifting heavier weights as I get older, which is very satisfying. And I enjoy reading and just relaxing whenever I have free time, but I'm usually trying to learn something new in medicine, whether it's emergency medicine or preventative health or something like that.
That's awesome. Thank you so much for sharing. And I hope our listeners are excited to learn more about you as we go along in this podcast. So let's dive right into HelloFam's mission, which is increasing longevity. So, can you start by telling us your definition of longevity and what it means to you?
Sure. So my definition of longevity is not necessarily adding years to life, but adding life to years. And I, I see people at the worst part of their lives often when they're told they're never going to walk again, or they're going to a nursing, they're going to be going out of the hospital to a nursing home. So I want for myself and my patients, if I can get to them earlier, to enjoy their seventh, their eighth, their ninth decades. I want people to have mobility, to be able to go for a walk, go for a hike, and definitely get out of a chair. You need to have your cognitive resources. You need to be able to continue to learn and engage and work if you want to work. Some people love to work. So I think it's just really important that you apply the levers early in life so when later comes, you're ready. And I think there's a lot of levers. There's some things that's just genetics or bad luck or whatever, but there are plenty of levers that we can push or pull to make us functional in those later years. But you have to know what those levers are and you have to participate.
Yeah, exactly. And thank you sharing also your personal experience being an ER doctor. And then again, like how do you apply your motto of strike early and strike strong with patients and yourself?
Yeah, that's a great question. So strike early, strike strong. I apply this to risk factors and lipidology. So I have a personal story that I want to share, and that's sort of how I got involved with both HelloFam and Move. As I said, I've been an ER doctor for many, many years. As a physician, thought I felt like I knew what health was. I didn't see a lot of primary care doctors over the years, but I got my labs checked every year, and my lipids were good. My metabolic function was always pretty good. I stayed in shape. I was always active. I had a reasonably good diet, a reasonably good weight. Participated in martial arts, and I did an 8-hour belt test when I was 50, which was basically 8 hours of fighting, running, all sorts of crazy stuff. I'm like, my heart's fine. And then one day, less than a year ago, actually, March in 2020, it was actually, I went to a primary care doctor just over a year ago because I needed a referral. And he said to me, I want you to get a calcium scan. And I said, why? He's like, because I want to check your heart. I'm like, my lipids are good. My blood pressure's good. I don't smoke. I don't drink. I don't need that. And what are you going to do about it if I get it? And I refused. And then a few things happened. Somebody that I didn't even know, but somebody, a friend of a friend who was my age, had a cardiac arrest and lived, but I was told pillar of good health. And then I started reading Peter Attia's book, Outlive, and learned his story. And I said, I think I'd be an idiot if I didn't get this calcium score. So in March of 2024, I got this calcium score. And surprisingly, I was off the charts in a bad way. So my score was 90th percentile for age and sex. And I was horrified. I'm like, how could this be? I've got a LDL cholesterol of 70. I've got normal blood pressure. So I totally freaked out. Um, Started a statin, started taking aspirin, and my doctor wasn't really that worried, but I was worried. So I started kind of combing the internet looking for, what do I do to reverse calcium? There really wasn't any imaging tests I was aware of or any other advanced blood tests. So I started looking around. I'm seeing all sorts of stuff all over the place. I'm seeing cardiovascular surgeons saying that the key to heart disease is start the carnivore diet because that will reverse your heart disease. I'm like, interesting, but that doesn't really sound right to me. So I was trying to get in with this world esteemed lipidologist who's in town that I heard great things about, but he's got a wait list years long, and I couldn't get in with him at the time. So I said, I didn't even know what a lipidologist was until I found out about him, but one of my dermatologists actually recommended him. So I looked up lipidology and I said, I wonder if I can learn how to be a lipidologist and that will help me kind of get the right information about my heart. So I'm not combing X and Instagram and YouTube and not knowing what kind of information I'm getting. So I went to the National Lipid Associated website. I called them. I found out I could qualify for certification, found out what the training was. It wasn't too expensive. And I started lipidology training early in 2024. And so this way, I'm going to the source. I'm going to the expertise, to the evidence-based, the world's best people in the world. And in addition to getting that expertise, I was loving it. I was fascinated by the biochemistry, by the sciences, and all that. And unfortunately, I finished my training. I'm getting ready to take my boards, hopefully in the next couple months. But fortunately, I did get in with this lipidologist who I was trying to get in with, and I got my health squared away. I've had some really encouraging news. He basically said to me at my visit last month, he said to me, the chances of you having a clinically significant cardiac event in your lifetime is close to zero based on what I'm seeing today. And that's a combination of several of these levers that I applied on my own, and he helped me apply, and my previous primary care helped me apply. So did a lot of things. Okay, so Strike Early, Strike Strong was an article published in the European Journal of Acute Cardiovascular Care in 2022. And that was really just changing the paradigm of going really aggressively, really quickly on LDL cholesterol in patients who had an acute coronary event. So I've extrapolated that into my personal life and for patient care in aggressively working on risk factors as early as possible in life. Because cardiovascular disease does not come on all of a sudden. This comes on over decades. It starts in childhood in most of us, especially now. And it's clearly evident in teens and your 20s. So the earlier that you start modifying your risk factors, the better your prognosis is going to be. So the way I like to look at atherosclerotic cardiovascular disease, and just to be clear, it's heart attacks, it's strokes, it's kidney disease, it's peripheral vascular disease. It could even be abdominal disease, because once your blood vessels get blocked with plaque, you can have serious problems. And the way plaque works is you start out with risk factors, and there are many risk factors which we can go over. But there's some familial stuff and genetic stuff that you can't control. But if you aggressively work on those risk factors, you can prevent the disease. Now, the disease is atherosclerosis, so that's plaque in your arteries. And most of us have this. A lot more people than they think have this. And we can go into some literature later, but up to 93% of men and 88% of women in middle age actually have subclinical plaque that most of them are probably not aware of, because these are asymptomatic patients, and we can go into the evidence behind that. But then you have disease, and your disease will progress. And it's okay to have disease if you have it, but you don't want your disease to progress anymore, because once your arteries get fully clogged, then you have an event. And that event could be a heart attack, it could be stroke, it could be sudden cardiac death. You can lose a limb. So by striking early, strike strong, you want to get patients either at the risk factor level, or the early disease factor, or the early disease level, or even at the late disease level. There is evidence that you can regress plaque. There's not a lot of evidence, because we haven't been able to look at plaque for that many years. That's pretty new technology. But there's some evidence that if you aggressively treat lipids, insulin resistance, inflammation, you can regress plaque. So you can have plaque in your heart and have less plaque in 5 years if you do the right things. So that's strike early, strike strong in a way I like to manage that.
Mhm. Awesome. And I think you were touching on this for my next question, which was actually what are some evolving evidence and studies being conducted into lipidology right now?
So things I'm most excited about are artificial intelligence and imaging. So CT scans and MRIs, particularly CT angiograms. There's new technology that this is actually accessible to the public. It's consumer based, so you have to pay for it. Insurance isn't currently covering it. But you can get a CT, and I actually had one of these very, very recently. You get a CT angiogram, which is minimal radiation. It's a little bit of dye. It looks at the vessels. That's generally, the CT angiogram itself is generally not helpful if you don't have symptoms. So if I can run 3 miles at a 8 or 9 minute mile and I don't get chest pain or shortness of breath, there's no reason that I would have clinical disease and the CT angiogram wouldn't be helpful. But when you use AI, the algorithms know how to read for subclinical plaque. So you may not have narrowing in the vessels, but you can see plaque, and you can see how much plaque somebody has. You can see where the plaque is located, and you can even see the phenotype of the plaque. What type of plaque is it? Is it high risk plaque or is it low risk plaque? Because the honest answer is calcified plaque is almost no risk. It shows that you have plaque, but you've calcified it. It's not going to be a problem. And there's non-calcified plaque. Non-calcified plaque is a little bit more worrisome, but it's usually not a huge risk. But then there's something called low density, very low density fatty plaque. So that's the type of plaque that's fresh. That's going to potentially break off and cause cause a clot, cause a heart attack, cause a stroke, cause an event. So by having some of this AI imaging stuff, you can actually see what's going on in your arteries, and you're not extrapolating based on a calcium score, which has utility in prognosis, but doesn't tell you what's really going on in your vessels. Lipids and things like that tell you if you're at risk, but they don't really tell you, do I have plaque? Do I not have plaque? So the imaging is huge, and CT scans are doing it, MRIs are doing it. So that's really exciting. And I think the other technology, which is really exciting, is the lipid lowering therapies. Everybody's aware of statins. We'll talk about that a little later. I think statins are fantastic, but there are some really innovative drugs that have come out or coming out within the last 5 years or within the next 3 to 5 years. And these are drugs that can be injected subcutaneously once every couple of weeks, once a month, once every 6 months. And these are almost like they're mRNA type of drugs where they silence the proteins in the mRNA, and they work on the various proteins that cause that we can affect the lipids in the blood. So the LDL receptor is a big one. So if you upregulate your LDL receptors, which most of these drugs do, not all of them, then you pull the cholesterol and the LDL and the apoproteins out of your blood. And once they're out of your blood, they're not causing a problem. Having them in your body isn't a problem. Having in your bloodstream is a problem. So if you
Mhm.
go after the PCSK9, which kind of works on the LDL receptor, you can, upregulate that and pull all the cholesterol out of your blood. And some people with genetic disorders, they don't have any LDL receptors, so you can sort of work on creating those type of things. Um, and there's
Yeah.
even gene editing therapy now that you can get. There's some trials; they're not out for the public, but a single injection can affect whether it's your LDL receptor gene or ApoB gene, and you can get one injection early in life and potentially never have to worry about taking a medicine again. So that's pretty
Mhm.
cutting edge, exciting, not out there yet. Maybe 5 years, maybe 10 years. I'm not sure when it comes out there. And then finally, we'll talk about this a little bit later, is LP little a, which is another genetic condition that 1 in 5 of us have. 20% of the people in the world have elevated lipoprotein little a, which is very atherogenic. Most people don't know they have it because most people haven't tested it. There really aren't any approved drugs for it right now, but there's two in the pipeline that could be out within the next 5 years that will be able to treat patients who have that genetic disorder, which is, as I said, 1 in 5 of us. So that's what's exciting. There's more stuff out there, but that's just some highlights.
Yeah. And again, like we were talking about LDLs, and I was looking into it, and there are a lot of like experts, including physicians online, saying that LDL does not matter and that statins are poison. So how would you respond to those claims?
So cholesterol research, LDL research is probably if not the most, it's probably top 5 most studied, you know, um, parts of medicine. We've had decades of studies. You have Mendelian genetic studies, millions of patients that show there's a causation between, or association at least, between higher LDLs and more cardiac events and lower LDLs and fewer events. You have observational studies such as Framingham, which I think everybody's heard of. Same thing. The higher your LDL, the more likely you're going to have atherosclerotic coronary event or death, the lower the LDL, the fewer deaths you can have. Again, millions of patients have been enrolled in these observational cohorts. And then you have RCTs, randomized controlled trials. And there's been hundreds of thousands of patients enrolled in these randomized controlled trials, which are amazing. Some of them are statins, some of them are some of the newer drugs, but every one of them has shown that if you decrease your LDL, your ApoB, your non-HDL cholesterol, and we can talk about all the differences in all those, but if you decrease those, you will have fewer events. So this is even in patients who have normal LDLs. So you can have, and I had normal LDLs and I had plaque, but you can have normal LDLs, and by lowering your LDL, you will have fewer events. And then there are meta-analysis. Again, meta-analysis, hundreds of thousands, maybe millions of patients. There's the CTT, cholesterol trial, I think it was 170,000 patients were enrolled. And that basically showed for every 39 milligrams per deciliter that you reduce your LDL cholesterol, you will have 22 to 25% fewer cardiac events or atherosclerotic events in a 5-year period. And that's a 5-year period. So that's huge. And then you scale that. So if you have a 20 something or a 30 something year old patient who could live to the 90s, like you're going to decrease if you're dealing with that specific risk factor early, you're going to decrease events almost exponentially, 70, 80% over a lifetime if you start early, strike strong. So that those are studies that have essentially proven the LDL hypothesis is not a hypothesis. It's basically lower is better. So we know that. And I'll just say what the deniers are doing, and this is just a strategy I think people need to be aware of. It's something called reverse causation. And what that means is, so they're showing some studies where people have higher death rates at lower LDLs. And these are legit cohorts, but these studies are basically, so what happens is if you're frail and elderly, if you're malnourished, if you've got end stage liver disease, if you have end stage cancer, your liver is just not manufacturing lipoproteins or LDLs. So you're going to have really low LDLs and you're going to die because of your other disease. It's a confounder, is what it's called. So you're going to die from your end stage HIV or your end stage cancer or your malnutrition or your liver failure because of that, and you're going to have low LDLs. So some of these quote unquote influencers are showing these studies and saying, look, you've got lower LDL and the death rate's higher. So it's reverse causation. So I just want people to be aware that's a strategy when you see somebody post up a study. So for me,
Hmm.
like as I said, I was seeing all this on the internet as a physician who kind of knows how to evaluate studies and very confused.
Hmm.
But and in every clinical body, the European Society of Cardiology, the National Lipid Association, the American College of Cardiology, the American Heart Association, every one of those WHO, all show the evidence lower is better. And if you have high LDLs or high non-HDL cholesterol or high ApoB, you need to lower it in most cases.
Thank you, Dr. Jeff Sternlicht. I will be honest, I did not know that much about LDLs and statins, so that was very informative. And knowing that there's evidence or research papers being put out or articles being trying to, I guess, misinform and connect different types of, I guess, correlation not equaling causation is something I'm definitely going
Exactly.
to be looking out for and important to HelloFam as well. And we'll make sure to include that, maybe even write an article or at the KOL studio, you even put out an ASCVD article, which I really found informative and interested in reading. So thank you. And just to round off the podcast, I'm going to ask one last question. So you have mentioned books like Outlive by Peter Attia. Are there any other books that you would recommend to us and the users about healthy living and just being well informed?
Sure. So as part of my journey last year, I read a lot of books or listened to a lot of books, and Outlive was clearly a life changer for me and most people who've read it. The other book I read I really enjoyed was something called Good Energy by Casey and Kelly Means. I don't agree with everything they wrote in the book, but I agree with most of it. And the view of metabolic health and, keeping your glucose under control, because insulin resistance is a real thing and it's a real problem for cardiac vascular disease in addition to other things. So I thought that book was really changed my way of doing things. William Lee wrote a book called Eat to Beat Disease. It was an amazing book, and it talks about what foods you can eat to make yourself healthier. And there's real evidence behind it. There's real evidence behind food and eating good whole foods. So I would recommend that book. And the other book I thought it's not really known as a health book, but it's called The Comfort Crisis. And that book was really amazing storytelling, and it kind of goes back to just primordial living. And it's not really look using technology or cutting edge things, but it talks about how fasting is good, how calorie deficits are good. You may not need to be doing some crazy activity, but just walk a lot, hike a lot, carry your rucksack, be resilient. The heat and cold therapy and things like that, which have been proven, heat therapy has been proven to decrease cardiac events up to 60%. And he talks about that and with really good storytelling. So those are the four books that I would recommend anybody to read. I think there's a lot of good nuggets in those books and they're very entertaining. And I couldn't put them down.
Mhm. That's awesome. I'm definitely going to add that to my book list for 2025. So, again, thank you for sharing your story and being so open about it. We are glad to hear you're doing much better. And thank you for coming onto the podcast. I definitely think our users will enjoy this one. And I wish you a great day.
It's a pleasure being here. Thank you so much for the opportunity.